Exablate 2000. Ultrasound imaging is a widely accepted diagnostic tool. Now, ultrasound is available as a therapeutic tool for tissue ablation as well. MR-guided focused ultrasound combines high-intensity focused ultrasound waves with precision MR imaging and guidance to provide non-invasive treatment for uterine fibroids. Focused ultrasound energy is delivered to one point at a time. A high-intensity ultrasonic beam, called sonication, passes through skin and soft tissue to focus on the target, raising its temperature to between 65 and 85 degrees centigrade, while not affecting surrounding tissues. This results in protein denaturation, irreversible cell damage, and thermal coagulative necrosis with a sharp delineation between them. The concept of focused ultrasound as a non-invasive surgical option has been investigated for over 60 years, but only with the development of precise visualization and guidance tools, such as magnetic resonance, has this potential translated into a safe and efficacious treatment modality. How does MR guidance ensure safety and efficacy? High-quality visualization. MR's precise high-quality cross-sectional anatomic resolution enables exact targeting of tumors and visualization in 3 dimensions. T2 weighted MR scans show the pelvic anatomy in excellent detail by slice. This sagittal image shows the spine, uterus, and uterine fibroids. This slice of a different depth shows the endometrium in green and the other anatomical structures. The axial orientation shows the uterus, uterine fibroid, bowels, sacral nerves, and pelvis. The coronal view shows these organs from a third orientation. This visualization enables the physician to clearly identify the anatomy and treatment target, as well as the energy beam path, to verify that the energy does not damage healthy tissue, ensuring safe treatment. A unique feature of magnetic resonance is the ability to measure thermal changes in the tissue, a measurement to predict tissue ablation. Every 3 seconds during the energy delivery, thermal MR images display the temperature buildup in the targeted spot and surrounding tissues, ensuring that the energy in the target is high enough for coagulation and not in the surrounding tissues. The evolving temperature graph shows the hottest temperature in the sonication. In addition, real-time magnitude images show the anatomy of the treated area. This continuous real-time thermal feedback helps the physician control the treatment, to know if the temperature reached the correct target and that it achieved the desired thermal impact. Temperature of surrounding tissues is also monitored for safety, and anatomical images exclude organs motion or target misallocation. Exablate 2000 consists of 3 components. A workstation, which sits alongside the GE MR console, an electronics cabinet, which resides in the MR equipment room, and a patient table with a movable transducer. The ultrasonic transducer is immersed in a sealed liquid bath and is moved and tilted by a positioning system which moves back and forth, and rolls, and tilts. The transducer generates the beam of focused energy which passes through the liquid bath and acoustic coupling gel pad to reach the targeted tissue without affecting the surrounding organs. The depth of focus in the body is controlled electronically. The patient table is docked to the MR system, and treatments take place within the MRI scanner with the patient lying prone on the patient table. The patient is prepared with an IV catheter to deliver medications and MR contrast, and has a Foley catheter to keep her bladder empty during the procedure. The treatment planning and the entire procedure are conducted from the Exablate workstation, which is closely coupled with an MRI scanner. Exablate works only with the GE MRI scanner. Images of the pelvic area are acquired by the MR scanner and retrieved by the Exablate system. From this point on, the Exablate system interfaces with the MRI, and all operations are performed from the Exablate console. Two rows of scans are displayed in strips of images along the top of the workstation screen, displaying slices of two orientations, axial, coronal, or sagittal. The physician selects the treatment area and draws them on the coronal scan. This is confirmed in the other orientations. As a safety measure, to prevent the energy beam from passing through sensitive organs such as pubic bone or bowel, and to limit the energy density at specific areas, like skin or bone surfaces in the far field, contours are drawn around these organs. After drawing the contours, the system automatically checks the beam path of each sonication point. The system issues a warning if the energy density exceeds set safety limits. Fiducial markers are added as an additional safety measure. Major points of anatomic reference are marked to help identify patient movement. Based on the tumor volume and depth of the prescribed treatment volume, the system computes the energy, number, and size of spots appropriate for the treatment. The spot is cylindrical in shape and can vary from a few millimeters to 10 millimeters in diameter and 45 millimeters high. The sonication spots are colored to provide additional safety feedback. The spots are usually green. Yellow or red spots warn the operator that the energy density of the spot is higher than the safety threshold. In such cases, the operator checks the targeted energy beam path to determine that nothing interferes with the energy beam in any plane. If needed, the pitch and roll functions can be used to change the angle of the beam or change the near or far field beam path to avoid bowels, surgical clips, scars, nerves, or any hard implant. At any point, the physician has extensive control over each sonication parameter. The physician can add, delete, or move spots, modify energy levels and energy dispersion, modify spot size, and spots density. This control enables the physician to optimize the treatment and to enhance its safety and effectiveness. Thermal imaging is used to verify system calibration and dose suitability. First, a low dose of energy, too low for necrosis, is used to identify the actual point of energy delivery and adjust small beam deflections caused by patient-specific tissue deviations. Next, a full dose of energy is used to verify that the planned dose reaches 65 to 85 degrees needed for thermal ablation. This confirms that the energy selected is neither too hot nor too cold. If so, adjustments are made. At any time, parameters can be altered to obtain the desired results. Exablate treatment consists of multiple sonications, delivered in a planned grid until the entire tissue volume is treated. Each sonication lasts about 20 seconds with a scaled cool-down time. When the sonicate button is pressed, the MR begins scanning, energy delivery begins, and real-time thermal images and temperature graph are displayed showing the temperature buildup. The physician knows immediately if the focused ultrasound energy has reached the planned spot and temperature. After each sonication, the ablated area is displayed in blue as accumulated dose. In addition, real-time anatomical magnitude images are shown to verify the location of the sonication. The tissue temperature in the focal volume reaches 65 degrees, but because the temperature fall-off is sharp, the temperature of surrounding tissue is not raised. 4 millimeters from the spot, the temperature is normal body temperature. To increase treatment speed and safety, the system automatically develops a treatment map to maximize the number of successive sonications without beam path overlap. The patient perceives only limited conscious sedation and provides feedback throughout the procedure. At any point, she can press the handheld Stop Sonication button to immediately stop the sonication in case of pain or discomfort. Based on the continuous real-time feedback during and after each sonication, the treatment plan can be modified by adding or deleting spots or changing parameters to minimize patient risk or to optimize treatment. For example, if the temperature is too low, the energy can be increased to reach a higher temperature, or, if needed, it can be lowered to reduce the temperature. To avoid sensitive structures in the near or far field, the transducer tilt for that sonication can be modified at any time. Sonications are repeated until the planned tumor volume has been ablated. The accumulated dose map displays all the areas that were necrosed. Post-treatment contrast-enhanced MR images enable the physician to verify the immediate treatment effects. Coagulated regions caused by the ablation process are clearly seen as non-enhancing areas. The coagulated areas are slowly cleared by the body, reducing fibroid mass. This extent of ablation provides a measurement of treatment success in terms of patient symptoms improvement. This is an example of an accumulated dose map and the non-perfused volume at the end of a treatment. Post-treatment, the patient is observed for 1 to 2 hours while recovering from sedation and is then released home. Most patients do not require prescription medication for pain and resume their normal activities in 1 to 3 days. The combination of focused ultrasound and magnetic resonance guidance using Exablate 2000 provides MR precision visualization of anatomy and energy beam path for careful targeting, continuous real-time thermometry for monitoring and control, and closed-loop feedback, all to help ensure safety and efficacy of the MR-guided ultrasound treatment.